down. Those at the back, could you shut the doors? Thank you. Well, look, welcome back to the second of the policy debate sessions. And this time you get out your card with your QR scans and you scan in the second policy session 2, which is a different code to the one we had before lunch. So I'll let you get organised. Okay, same rules as before. 5 minutes for the person proposing the motion, 3 minutes for their seconder, should they choose to take it, 3 minutes for subsequent speakers. And if passed, the motion goes to Federal Council to be further developed. All right, all ready? Thank you. Well, I welcome Dr. Jill Tomlinson to the podium for the first policy issue.
Thank you, Chair. Intimate partner violence is the leading contributor to ill health and premature death in women under 45, more than any other known health risks, including high blood pressure, obesity and smoking. The occurrence of non-lethal strangulation in domestic and family violence situations is a serious act of violence. It can cause serious psychological and physical harm without any obvious signs on the body. And it's an indication of increasing severity of violence and is a significant risk factor for future homicide. A woman surviving non-fatal strangulation is 6 times more likely to subsequently be subjected to an attempted murder and 7 times more likely to be subsequently murdered by her family violence perpetrator, underscoring the importance of screening. Non-fatal strangulation can also result in permanent physical disability, in many instances without external signs of injury, and this disability can be incorrectly attributed to other causes. It can cause brain damage, pneumonitis, miscarriage, acute myocardial infarction, injury to the carotid arteries, post-traumatic stress disorder, memory loss, vocal cord dysfunction, depression, anxiety, and delayed death that can occur days or even weeks after the assault. Non-fatal strangulation also affects victims psychologically. It's a potent weapon used to instill fear and increase control over a family violence victim. Because injuries from non-fatal strangulation can have no external signs, and because of the greatly heightened risk of death at the hands of a perpetrator, it is vital that medical professionals ask women about non-fatal strangulation and be aware of the potential physical injuries that result and the subsequent risk of murder at the hands of the perpetrator. Education of professionals and the public can play an important role in addressing the health issue of non-fatal strangulation, so that victims of family violence and their doctors are aware of the increased risk of death and disability, including permanent brain injury.
Thank you. And the seconder, Dr. William Tan.
Colleagues, non-fatal strangulation is a medical problem underpinned by scientific evidence. There are significant health and social implications of this important issue, and the AMA is in a position to take a leadership role into this, beginning a discussion into this important societal problem. I urge you all to support this motion. Thank you.
Thank you very much. Any speakers? Could they move to the microphones? Speaker at microphone 1, thank you. Introduce yourself, please.
Michael Cleary from Queensland, and I've turned the microphone on this time. So I rise to speak in favour of the recommendation, of the motion rather. Some people may be aware that in Queensland there was a report 4 years ago, not ever, which then resulted in the formation of a task force to oversight a whole series of changes in Queensland, The AMA Queensland presented at the task force last year and spoke particularly strongly on this issue, and that has resulted in a commitment to undertake training of the health and related workforce in Queensland. I think it's really important to recognise that maybe 40 to 50% of homicides have this as an antecedent symptom, that often it is not able to be picked up by external examination of patients, and if there is a history of non-lethal strangulation, that increases the risk of subsequent homicide and domestic and family violence situations by as much as 700%. So thank you, I support the motion.
Thank you. Microphone 2.
Thank you. I'm Mukesh Harkawal, I'm a GP in Melbourne. I'm rising to support the motion, obviously, but mine, I suppose, is a bit of a question of how, and also an observation. Michael spoke about stuff happening in Queensland in this space. I'd like to speak about stuff in Victoria. We've had a Royal Commission to this and some really strong recommendations and significant funding in the domestic violence area. I work with an agency called Brain Injury Australia, and one of the key drivers in the younger age group of brain injury is violence against women in particular. And certainly this methodology is unfortunately part of that brain injury being resultant. So my comments would be absolutely support this. Number 2 would be, can we work with other people in this, not just AMA alone? There's very many parties that can work in this space. And of course, across the states and territories, we have great pooled resources. We should pool them. Thank you.
Thank you. Second speaker at microphone 2. Introduce yourself. Thanks.
Hi, I'm Sandra Hiro-Watari, Chair of the AMA Council of Rural Doctors. I very much support this motion. I feel like it could be strengthened because the way it looks, it sounds like a one-way street, that we should be looking at the implications of non-fatal strangulations. I think we should also look at what would also implicate that a non-fatal strangulation could have occurred. For example, bruises on the woman's left upper arm is quite often correlated with strangulations. Violence of any form should allow the doctor to focus over towards the neck. And so I think there is a two-way street here that can be added to our investigations as AMA, and I'd like to say that I fully support this attention.
Thank you. No other speakers to the motion? Okay, well, we'll open voting on the motion that our AMA promotes awareness among medical professionals of the risks of non-fatal strangulation and includes mention of the risks of non-fatal strangulation in the next iteration of the AMA policy on family and domestic violence. Okay. Voting closed? Yep. And the motion is carried. All right, next, Dr. Richard Kidd, could I ask you to come up to speak to your draft motion? 16% of the federal health budget should be mandated minimum spend on general practice.
Thank you, and I probably should just warn people, if I start speaking gibberish, it's sleep deprivation. There's practically been none for the last 48 hours, but a beautiful baby boy has been thrilling. So the CGP is very supportive of this idea. I probably should just clarify at the beginning that we're not actually asking for anything very different from current AMA policy, which is that 10% of the total health budget should go towards GP funding. We're just really clarifying it and trying to pin it to where it belongs. General practice funding, by and large, is in the federal space, and it's the federal government. So by asking for 16% and having it mandated of the federal budget, the federal health budget, it really is about the same as the 10% that we've already got as our current policy. So we just really want to clarify it, mandate it at that level. Yesterday, and we've had this big discussion earlier today, I overheard a GP registrar talking about how her income now is less than it was when she was an intern, and she's pregnant and she's not going to have maternity cover when she moves, maternity leave when she moves to her next job. Yesterday we had Minister Greg Hunt talking about that fundamental importance of general practice to the health of the nation. And he noted we're number one in clinical outcomes, but not in access or equity. So, we need to do more. Starfield and others have really pointed to the importance of general practice and the difference it makes if you better fund and resource general practice. You actually get substantial return on investment. We've got evidence recently that going to your usual GP means that you'll live longer and live better. And here in Australia in the last 20 years, we've seen health reform upon health reform with many recommendations to strengthen and increase capacity and access in general practice and primary care. But there's been no really significant new investment. And general practice is already the most cost-effective part of the health system, but it's under stress. And we've been increasingly asked to do more and more for less and less. And that was sadly the failings of the government's healthcare homes, that it was a great idea, but there was no real resourcing, there was no new investment. I chose to become a volunteer in Papua New Guinea many years ago, and it was fantastic, and I chose that to be a volunteer. But now the Australian system is really asking general practitioners in particular to do something like that and do a lot of charitable work. And what I mean by that is that I've got a family to look after. I charge what I believe I'm worth, and my patients who can afford to pay it tell me I'm worth every cent of it. And yet I feel obliged to bulk bill my aged care residents, and you heard me speak with passion about that yesterday, and some of my patients who I know are in difficult financial situations. And the Medicare rebate for me is only a third of my fee in many cases. So fee for service is still the cornerstone, and it's a very effective and efficient mechanism. But in general practice, increasingly we're being asked to do more that is not being funded at the moment. Activities that are around care coordination and telephone consultations and emails and messages from patients. And this is becoming an increasingly difficult issue for general practice. We have the AMA medical home model and community, and we have a model that we can use here to expand on, which is the DVA's Coordinated Veterans Care Program. And we have other things to think of, like Bodenheimer's 4 aims. And for general practice, it's particularly important to think of that 4th aim now. So what I'm getting at with all of that is that this is really all about the patient. This is about getting better, more efficient, effective services where they should be, close to the home, through the general practice, through primary care. Denmark's done that. They've reduced the number of hospitals they've got from 36 to 8, I think. And we need to have a system that will work. So a mandated 16% of the federal health budget will help that work. So as I said, it's all about the patient, better access, better equity, better coordination of care, and better health. So I strongly recommend that we go for this mandated 16% of the federal health budget. Thank you.
The seconder, Dr. Torvaldsen.
Well, as Richard said, we know that promoting and empowering general practice leads to better health outcomes and reduced costs. There's been lots of studies to show that from Starfield onwards. We've got evidence from within Australia. The question is, why isn't it happening? We've had lots of reviews, we've had lots of recommendations, and yet nothing much has changed. And the current system, it's very difficult to give quality care without adequate resources. So there's a simple answer to all of this, and the answer is that the benefits that we bring are relatively long-term benefits. It takes years for preventative health and the kind of work that we do in general practice to save that money and to produce those outcomes. And unfortunately, no politician is interested in anything beyond the 3-year election cycle, and preferably in the next year or two. So there's always something else that has to be funded instead. And this is actually costing us billions of dollars every year. It means our health system is less efficient. It means our outcomes are not as good as they could be. And we need a solution that is simple, understood by everyone, bound by legislation, and can't be undermined every time there's a change of government. And we're not talking here about reducing funding to any other part of the health system. What we're actually asking for is a relatively small mandated investment. It works out to be about $2.5 billion a year, which is something in the order of about half of the increase in the overall health budget over the last few years, year on year. It's about half the increase between 2016 and 17. So although it's a large sum on its own in context, it's actually not so large. And when this was done in Oregon and they did put more funding into general practice there in primary care, the result was that they ended up long-term saving $13, they estimate, for every dollar that they spent. So 16%, it's about 10% of the total health budget. We're actually only asking for you to consider a way of implementing what is current policy and actually just turning our policy into reality. This is a mechanism to make it happen. $2.5 billion from our own internal AMA modelling is sufficient to transform general practice in this country, to reinvigorate our health system and produce better long-term outcomes. It should be a no-brainer for government. Because of the political cycle, it's not. And what we're asking for you is to help us turn it into reality.
Thank you. Speakers to the microphone. Microphone 2.
Maria Bolton, AMA Queensland Council member. As owner of a large medical practice in Brisbane, I support this policy as general practice is in crisis. If more funding is not made available quickly, it will mean the end to doctor-owned general practices. As a business owner, rebates have not kept up with increasing complexities of care, rent and wages. The benefits of general practice care have been proven. Let's support it and make it happen.
Thank you. Second speaker, microphone 2.
Marco Giuseppe, GP Registrar Chinchilla. Brief statement in support of this motion. I think that this is essentially a bare minimum percentage for general practice that should be guaranteed in our health budget. As we've mentioned, the return on investment is huge. Putting my cynic's hat on, I think that having a number, particularly a legislated and mandated number, gives a politician something to brag about. In secondary care, we often see politicians and hospital care enjoying having photo opportunities next to machines that make expensive sounding noises, and that's very hard to do with general practice. So having a mandated number that they can say we will meet and potentially even exceed actually even gives our politicians something to work towards. So for that reason, I speak in favour of the motion. Thank you.
Thank you. Microphone 1.
Thanks. So I'm Ken Singh Lim, General Practitioner in Western Sydney. So I also speak in favour of the motion. I'm going to introduce a couple of other points. And that is that if we are talking about 10% of total health spend, this matches what the NHS started with and what the British Medical Association started by recommending. They've moved this up to 12%. We can also talk about data from other evaluations, which have shown that you get anywhere from, and we're talking about very poor trials in Western Sydney, 2-to-1 return on investment, to very nice trials in other countries, which have shown as much as 8-to-1 return on investment. So we talk about how we have not got enough room in hospitals, not enough room to do all the things we need to do. And this is where it starts. And there is the opportunity cost of not doing it. And because if we carry on doing what we're doing, we go nowhere. And part of this funding is to enable that move to the future. Thank you.
Thank you. Any more speakers to the motion? All right, well then we open voting on the motion that AMA lobbies the federal government to increase funding for general practice so that it represents at least 16% of total health spending and that this figure be mandated. Voting complete? Yep. And the motion is carried. Okay, so we turn now to the next policy topic, and Dr. Japelia, credentialed pharmacists in rural and remote areas. Thank you.
Thank you, Madam Chair. So I stand before my colleagues at the AMA National Council, first and foremost for rural communities and also on behalf of our rural doctors. As with so many other issues, the rural and remote health sector, there is a gradient of deficit as one moves from major cities through to regional areas and then to very remote areas. Medication management reviews play an important role in reducing readmission related to medicine misadventure and addressing medication-related issues such as serious side effects. For older patients and those with complex conditions, medication management reviews can be extremely helpful. For my colleagues in the room who are not general practitioners, GPs undertake medication reviews in conjunction with appropriately trained and appropriately credentialed pharmacists, and often as part of a team care arrangement for chronic disease management of their patients. There is an MBS item number for a GP and a payment to the pharmacist. So what actually happens during a medication management review? The MBS states that participation by a medical practitioner in a domiciliary medication management review for a patient living in a community setting in which the medical practitioner, with the patient's consent, A, assesses the patient as having a chronic medical condition or a complex medication regime and not having their therapeutic goals met, and B, following that assessment, refers the patient to a community pharmacy or an accredited pharmacist for the medication management review and provides relevant clinical information required for that review to occur. And C, discusses with the reviewing pharmacist the results of the medication management review, including suggested medication management strategies. D, develops a written medication management plan following discussion with the patient, and finally provides a written medication management plan to a community pharmacy chosen by the patient. So the medication management review is provided by accredited pharmacists trained to undertake these tasks. There are two credentialing bodies, the Australian Association of Consultant Pharmacy and the Society of Hospital Pharmacists of Australia. And for accreditation, registered pharmacists must have a combination of professional experience, participation in the continuing professional development program, and evidence of completion of a relevant competency-based assessment, such as the certification of pharmacotherapy or the certification of geriatric pharmacist. And they've got to continue the registration. They've got to have completion of CPD requirements, which is mandatory to maintain their MMR accreditation. Currently in Australia, medication misadventure conservatively represents 230,000 hospital admissions each year at a cost totaling exceeding $1.2 billion. In rural areas, the probability of medical misadventure is often compounded, as many communities don't often have a regular doctor and medications are prescribed to the same patient by numerous practitioners such as hospital doctors, fly-in, fly-out locum GPs, fly-in, fly-out specialists, providing outreach services and nurse practitioners. And more often than that, these prescribers do not have access to a single medical record. In addition, many rural patients have their medications changed when referred to regional and tertiary centres. The AMA is ideally placed to assist governments at federal and state level to improve patient safety and, as a consequence, to contain this cost. Whilst credentialed pharmacists do receive a payment for providing the service, the limitation of 20 per month is not commercially viable for these pharmacists to pay for travel and accommodation costs, and therefore it is not attractive as in urban areas where they do not have this cost. The issue that I'm presenting here this afternoon for those communities living in modified Monash model 4 to 7, that means 15,000 and less population, has been debated and brought forward to this conference by our AMA Council of Rural Doctors, a committee that's made up of passionate GPs for some of the most rural communities of Australia. CRD is recommending that Federal Council debates and advocates for the removal of the current limit of 20 medication management reviews per month that can be performed by credentialed pharmacists, and therefore allowing these credentialed pharmacists to assist rural and remote doctors to manage their chronic disease patients better, safely, and part of a doctor-led collaborative team. I commend this motion to you.
Thank you. Seconder, Dr. Giuseppen.
Me again, sorry. So I come to you not only as a rural GP, but also declare my own interest as a former clinical and consultant pharmacist who decided I wanted to prescribe medications and manage my patients, so I did the sensible thing and went to medical school and got a degree. Look, thanks. It's with great pleasure that I speak against this cap on HMRs patients in rural areas, both for our rural doctor colleagues, for our patients, and also for my consultant pharmacist colleagues who believe in true collaborative care. If you think doctors are concentrated in cities, you should have a look at the pharmacy workforce. 92% of pharmacists work in inner regional or major urban areas. 92%. The number of credentialed pharmacists working in regional and remote areas is even lower. In fact, so low that you can't actually get a number. And these are people holding qualifications, as Dilip has said, from either the AACP or SHPA. These reviews are worth $219 to an individual pharmacist, so with a limit of 20 plus the $125 allowance they're given for travel, one-time allowance to a rural area, makes that service completely unviable for smaller towns. As of the advent of the 6th Community Pharmacy Agreement, the federal government took this decision to limit the number of HMRs to 20 per month. The reasons for this were entirely financial and cynical. The 5th CPA comprised the introduction of Meds Checks, an initiative of the Pharmacy Guild of Australia to allow ad hoc medication reviews in community pharmacy. No communication or collaboration with the patient's doctor is required, and at the time I started providing it as a junior pharmacist, were worth $50 to the pharmacy for each one performed, with no cap. In order to fund this and the overspend on it, the government took the decision to limit the number of HMRs an individual pharmacist could perform. This has had a catastrophic outcome for rural and remote Australia. Credentialed pharmacists who would previously happily travel to a rural town and spend weeks performing these reviews can no longer do so. In one town, my town, we actually have over 300 patients eligible for a HMR who've not received the service in the past 12 to 24 months. Patients with complex medication regimens who would benefit from this input. At 20 a month, you do the maths. HMRs are valuable services. The pharmacist visits the patient at home, obtains a comprehensive medication history, including OTC and herbal medications that patients, for various reasons, don't disclose to their GP. They comprehensively assess compliance and engage in a two-way discussion with the patient's GP about their pharmacotherapy. This is true collaborative care and represents a fantastic model of interprofessional practice that we as AMA should advocate for strongly. This arbitrary limit of 20, introduced for the financial benefit of the Pharmacy Guild, is discriminatory and differentially affects patients in rural Australia. This is good medicine, good pharmacy, and good collaboration, and should be encouraged by our association. Thank you.
All right, speakers to the microphones, please, and microphone 2.
Well, as a GP in a metro area, and as a GP, I'm feeling a bit conflicted about this because I'm strongly supportive of what Dilip is saying, but I'd like to see this extended, in fact, to all areas. It's incredibly difficult, even in a metro area, to get proper medication reviews done if we have this limit. I'd love to develop a relationship with one pharmacist for my practice, but I can't. There's no business case for them. So while supporting the motion, I would like to see the AMA push hard to get this extended to all medication reviews and including looking at the residential aged care facilities.
Thank you, and that was Dr. Torvaldsen. Second speaker at microphone 2.
Danny Byrne, GP in urban Adelaide. I'd support this motion. We actually employ a pharmacist in-house one day a week and have easy access to the 20 cap, and then she's able to liaise with other pharmacists to get another 20. We have an excellent relationship. She's an asset to our practice. We fund that out of the partner's own profits, but we just feel it's a really useful addition to our quality primary care. So I feel sorry for the urban guys, the rural guys who got this cap. So yeah, I'd fully support this motion.
Thank you. Microphone 1.
Thank you. Nick Yim, GP, Harvey Bay.
Now, we can't hear you. If you could speak into your microphone. Yep.
Nick Yim, GP, Harvey Bay.
Thank you.
So I support this motion, and like my colleagues on other microphones, I would like to see this extended to all of Australia. So in Harvey Bay, we have an ageing population with huge amounts of chronic disease. I'm also an ex-pharmacist, and I also refer to my pharmacist colleagues for home medication reviews. And the reason behind this is I realise that they are the specialists in medications. Many of the patients are on greater than 5 medications, over-the-counter medications, herbs, vitamins. Without the pharmacists having a collaborative agreement with GPs with these home medication reviews, this would definitely improve the health of our community. Thank you.
Thank you. Next speaker at microphone 1.
Thanks. So I'm Ken Singh Lim. I'm a general practitioner in Western Sydney, and I'm getting bored of everyone supporting all these motions, so I'm going to say I'm speaking against the motion. And that's mainly because I'm bored with it. But no, the real reason is that there's 2 parts to this motion. The first part is what is the utility of the pharmacist working in primary care and general practice? The second part is actually how that is funded. So I'm 100% in support of the utility of pharmacists. I have got a practice pharmacist, have had a practice pharmacist for about 4 years now, and they are absolutely invaluable, especially in terms of the continuity of care, the assistance, and that multidisciplinary team which helps to make my life so much easier. But if we go with this, and if we persist with this meds management model, it limits what pharmacists can do. It limits us to the item number trap. So I would speak against this motion and suggest that we need to be pursuing other things such as our general practice pharmacist models that we have as AMA been supporting before.
Thank you. We'll stay with microphone 1.
Paul Bowd, I'm a paediatrician from Darwin. My daughter's a credentialed pharmacist, and she handles the fair bulk of chronic medicines management across the top end and down to Alice Springs. I spend a month out of 3 in remote communities, and Sally Ann often joins me, hitches a ride, comes to these remote communities. She adds value to those communities by looking at their pharmacies, helping them with their clinic pharmacies, working with the GPs to work through a lot of the chronic management of these very complex patients. But I think it would add so much more value to what she does if she were freer to visit these homes and spend more time. She has a good understanding of what's available in homes and what's not. But I speak in favour of this. I think it would add value to for what she does if she was given more freedom. Thanks.
Thank you. Microphone 2.
Hi, it's Sandra Hirawatari, the chair of the AMA Council of Rural Doctors. I, of course, support this because it came from our rooms, but I regret not adding a little bit to this draft motion. It was brought to my attention with the first speaker that the pharmacists need to go into the rooms for the completion of the MMR. And that has been a problem for us in outback Australia, especially with the Aboriginal people, as they don't want us inside their homes. So I would like to add, if it can be discussed in the AMA rooms, that the MMR also allows the patio or the veranda to be part of the patient's home. Thanks.
Okay, thank you. Any more speakers to the motion? All right, well, we'll open voting on the motion that AMA advocates for the removal of the limit of 20 medication management reviews per month. Credentialed pharmacists are able to perform in modified Monash Model 4 to 7 to improve patient care and reduce adverse medication events. And the motion is carried. Thank you. Sandra, are you ready now? So Dr. Hirawatari will present the next policy, implementation of a national credentialing platform.
Hello again, everybody. Greetings from rural Australia. Our policy debate topic has 2 parts, credentialing and scope of practice. Everyone in this room is credentialed in some form, and it is a very important process. It ensures quality of practice, definition of expertise, communication of roles, and in the end, it's about patient safety. Credentialing, however, is onerous for both the doctor and administration. It contains details that do not change over time and space. For example, a certified copy of my medical degree, a certified copy of my fellowship papers, and my mumps, measles, rubella, hepatitis A and B status will not change regardless of hospital, health service, region, state, province, or even country. The elements that do change over time are easy to update. For example, my flu vaccine status for this year. I think it's achievable to provide a secure, unified, central, national, and flexible repository of credentialing information. As a matter of fact, a private business does exists that provides this service. It is self-managed by the doctor. It is linked in real time to AHPRA's registration status. It is stated to be a free service to the user. However, if the hospital or health service does not subscribe, the clinician pays. The AMA itself have their own product. It's a portal. By the way, it's called Doctor Portal, and it's just outside the door over there. Just say hello to Fiona or Anita there. I believe our AMA product, this portal, can be expanded to provide an important service to our membership, and it meets an unmet need. Further, it could increase membership. I therefore ask you to support this motion that the AMA calls on the Commonwealth, state, territory governments to adopt a central repository for credentialing to store all relevant documents as well as providing a scope of library practice. Thank you.
Thank you. And the seconder, Dr. Kammerman. Thanks.
Thank you. Dear colleagues, I come to you today as a rural doctor and a long-time member of medical appointment advisory committees. Whilst they all have the same purpose and outcome, every state and jurisdiction runs their appointment processes slightly differently. But what do they all have in common? As Sandra has just said, evidence of qualifications, CV, references, indemnity, registration, police check, working with children check, visa status if you're not an Australian citizen, immunisation status. Each of these pieces of documentary evidence must be provided prior to the appointment being confirmed. Many of us as doctors will move several times in our career. Many of us hold multiple appointments. All of us will need a re-credentialing process at the end of our appointments. In the private system, many large organisations utilise private clearinghouses to maintain a register of their doctors' documentation. Reminders are generated automatically as each document expires. Doctors are then able to upload their new documents at that time. In the public system, we have got a largely paper-based system that requires provision of a complete data set with every application. This is dealt with manually, leading to loss of data and is a source of frustration to many clinicians and their assistants around them. Another piece of the appointment process revolves around scope of practice. In New South Wales, significant work has been done by the profession in providing widely accepted definitions around scope of practice for medical appointments across all disciplines and at varying facility service levels. This work could easily be extended nationally. Why would we do this? To support our members who not infrequently have to engage with and occasionally dispute with local facilities who make inconsistent decisions regarding scope of practice. A national central repository for credentialing data and scope of clinical practice library would provide evidence-based appointment information and save a great deal of time and frustration for many of our members. I'd like to second this motion.
Okay, thank you. Speakers at the microphones. Microphone 1.
Annette Newson, Rural General Practitioner. I would like to support this. I know the Rural Doctors Association is already looking at this as well, so it would give us an opportunity to work with other organisations, especially not only in medicine but in many other fields as well. Rurally, we are relying more and more on locum services and fly-in, fly-out services. I think we have to accept that not everybody wants to live in a rural area, but many people would like to help out a rural location via various models. Something like this would really aid that and would give us an opportunity to work with many other organisations who are thinking the same thing.
Thank you. Next speaker.
Professor Julie Quinlivan, private practice. I'm just going to sort of speak against it maybe from a cautionary point of view. In the ACT, they do use a centralised credentialing system for ACT Health, and it was breached late last year. And in an era of increasing identity theft and the value of personal information, to have that sort of information that's in credentialing potentially given to hazardous third parties in a data breach can cause significant complications for a practitioner. I'm in a head of an agency, and we have daily attempts by sophisticated foreign governments to hack our data. And so I think it's rather naive that any system where multiple individuals can put information in and out of a data set, it will inherently never be secure. And so when you think about the sort of information that's, if your credentialing data was hacked, would you really want all your information in a third party? The other thing is that credentialing information does need to be updated. scope of practice does change. The areas you work in clinically change. Actually, police reports do need to be updated. Working with children needs to be updated. So I think there's still, there's still going to be consistent need to update. I have to update every year for credentialing. So it's just a cautionary thought about risk-benefit. So I'm not really against it, but I just, having been subject to a data breach of a secure territory government, it's cautionary tale.
Thank you. Next speaker, microphone 1.
Hi, I'm Brendan Steinfort from Sydney. In New South Wales Health, Ramsay's, Adventist Healthcare use a common platform. I think it's called Mercury eCredential or something. It has all the reminders that come out. It keeps all the documents in one place. I find it very useful. All the data security things aside, I have to use it because I'm told to, otherwise I don't work. I just mentioned that there is that program and several other ones out there, and maybe we don't need to reinvent the wheel, and you could maybe look at what's already there and try to utilise that rather than doing it all again. Thanks.
Thank you. We'll stay with microphone 1 and then come to 2. So, Steve.
Steve Robson, also from the ACT. I would have thought the argument about data breach is an extremely good argument to actually only have one rather than have multiple individual, perhaps more vulnerable databases which could be hacked. It would make sense to have one secure one. So I would have thought the opposite implication from that.
Okay, thank you. Microphone 2.
Simon Torvaldson, GPWA. Look, I think that if this is a good idea, we should consider taking it one step further. And perhaps if it is considered to be a good idea, the AMA should consider actually hosting this database ourselves, using it as a service to members, and perhaps a service that we could actually outsell and be the trusted database, the trusted provider and the independent third party. And of course, you need to be a member to access it, or you might have to pay for it. It is a member service.
Thank you. Microphone 1.
Well, that's a great idea, but if it doesn't fly,
and could
I'm
you...
Sarah Whitelaw.
Thanks, Sarah.
I'm on the board of AMA of Victoria. I think the speakers have outlined the scope of the problem with regard to the administrative burden for doctors and health services well. We've heard about the approaches in ACT and New South Wales. And we've also been approaching this at a state level in Victoria for some time. And we're assured that the state government is developing a centralised service, but the timeline is not clear. I think there is value in calling for a nationally coordinated central repository. I imagine, as Brendan alluded to, the potential for duplication of resources and duplication of services and costs is absolutely huge on this issue. So I would very much support the concept of calling for Commonwealth coordination and collaboration on the issue, unless, of course, we decide to do it all ourselves.
Thank you. Microphone 2.
Me again, sorry. Marco Giuseppe, GP from Chinchilla. I'm actually going to style myself a GP anaesthetist because this is relevant to my credentialing in my hospital. I'm actually going to take a counterpoint and speak against this motion, and the reason I'm going to speak against this motion is because as of yet, we have no good harmony between states and territories on credentialing. As a GP anaesthetist in South Australia, I'm required to log all my cases, numbers, paediatric, neonatal and adult resuscitations in ED. In WA, I'm not allowed to perform a GA caesarean section. Only a qualified anaesthetist is allowed to do that. And in Queensland, I have to do an anaesthetic crisis course and prove that it's been done in the prior 3 years. That's just one example of the sheer variety of different credentialing requirements nationwide for one profession. And I think that until we can look at harmonising those credentialing and scope of practice requirements, it will be very difficult to collect all of the relevant information on a national credentialing platform. And whilst I think this is a good idea, I'm not certain that its time has come. Thank you.
Thank you. Any more speakers? All right, well, we'll open voting on the motion that AMA calls on the Commonwealth and State Territory governments to adopt a central repository for credentialing to store all relevant documents, as well as providing a scope of clinical practice library. Okay, well, it's like election night, isn't it? But, all right, the motion is carried. Thank you. Now, yesterday we did not have time at the end of the Doctors' Health session to discuss a draft motion, and we would like to bring that forward now. Tony Bartoni, the President, is going to speak to this motion.
Thank you, Chair. So yesterday we had a very, very good session on what I believe is a very important issue for us as an association to take leadership action on. We had a session where we looked at the recent history, we looked at recent activity, we looked at a lot of what has been done in data and research. We looked at recent key frameworks that have been potentially put up as a solution to this problem. We looked at, we acknowledged that there's been some recent pausing in activity and some confusion in a way forward. The motion here really speaks about sending a really strong message to all of us as part of this, as part of the medical profession, to take ownership of a critical issue and lead in the coordination of activity in that space now. Yes, I did put it as part of my presentation in my speech on day one in terms of a key action item for myself. I can bring this up as with Federal Council. So why are we raising it here? Because of its unique and overarching importance for the whole profession, and this is a perfect opportunity for national conference on this occasion to send the message in the open public space about how we see the importance of this activity to lead and coordinate action as a matter of importance, as a key item to address what we would all acknowledge is an extremely serious problem. I don't think I need to say much more. Thank you.
Seconder, Tessa Kennedy.
So I think the part of the motion I'd like to address is just the third part, because many of you may not have seen the draft mental health framework or whatever version of name we're giving it on any given day. And I think Jess described a lot of what is in it yesterday. Specifically, there have been some concerns through CDT that it is an imperfect document. I don't think that's any secret. But there is a lot of good stuff in it. I think there's been a lot of consultation, and many of the limitations of it have arisen because there's a shortage of really good evidence about what works in this space. However, through the consultation process, there's been a lot of consistency in the messages that have come from the profession about what we see as needing to change in the near future to improve and reduce the burden of mental ill health and distress among medical students, junior doctors, senior doctors alike. So I think we need to stop talking about it. I think we just need to get on with it. If we wait for a perfect document that is informed by multiple RCTs, it's never going to happen. I think we need to treat this like a quality improvement project, and I think we need to start by making the small changes that we think are going to change the game, both in terms of the way that we work and improving the culture in which we work. I think that somebody needs to own this. Somebody needs to kind of bring all the players together in this space. There are a lot of parallel actions going on right now, and we need coordination if we're to succeed. I think the AMA is really well positioned to drive this, and this motion, in some ways, when it was brought to me and I was asked to second it, I said, well, this is actually only suggesting that we start with convening this leadership group. It doesn't really get to the nuts and bolts of how it's to be implemented. So obviously there's a lot of discussion to be had there, but I choose to support it, and I would encourage you to do so as well, because I do think we need to get going. And if we don't coordinate it, I think we risk losing the faith of our membership that this is a high priority for us. And I think, as Tony said, we really need to demonstrate how passionate we do feel about this. So I commend the motion to you.
Okay, speakers to the microphone, and welcome Mukesh Haikwal in microphone 2.
Thank you very much, Chair. I obviously support the motion. Numbers 1 and 2 could be taken on block and passed without any comment, I'm sure. Number 3 is, where do we start? We do have a document. I absolutely agree that it's not perfect, and I agree that the issue is that you never will get perfection. We're not starting with a blank bit of paper, though. That's also important, because if we start from another blank bit of paper, we'd be another 2 years behind where we need to get to. The organisation that we're part of is absolutely well placed, because all denominations of the medical profession are within our walls, within the ways in which we work. It doesn't mean we are doing this without others, and I advisedly suggest to you the words in A and B of 3 are put there for very specific reasons. Having worked in that engagement field for quite some time, if you engage with someone as a pull-along toy and then you ignore them, you don't feed back to them, you don't tell them why you're making changes, why you haven't taken on their feedback, it's not going to go very far very fast. So I always talk about meaningful engagement and respectful engagement, and that's what this is trying to espouse. The way we should do this has to be bringing the people along us on our journey and doing this with them, together with them, not to them. Thank you.
Good. Thank you. Microphone 2, and then...
Yes, Dr. Kieran Allen, Doctor in Training and Psychiatry Registrar from Victoria. I strongly support this motion, and in particular know that many of my Doctor in Training colleagues have very strong support for this, and I commend Dr. Bartoni and Dr. Kennedy for moving this motion. In particular, I think that where the AMA needs to come in is in the role of leadership. What we are seeing is a space where the colleges, the employers, the regulators are shifting the buck of this problem, particularly when we look at service registrars and unaccredited registrars. No one wants to take this on. And as the leading voice of the profession, I feel that this is our responsibility, and I hope that you support this motion.
Thank you. Microphone 1.
Dominic Barbaro, GP, Victoria. I strongly support this motion. It is about time that it did come up in a formal way. Through the divisions of general practice in the past, we have always encouraged everybody to have a GP and not to self-medicate, which most of us probably have done it at some time. So it's a good time, and I really support that. Also, going to number 3, as President of the Medical Benevolent Association of Victoria, I have come across a lot of problems, particularly in the areas of mental health, and there are lots of medical students and doctors, some involved with the medical board as well, and the college authorities, and the stress caused by some punitive measures and professional and financial support that these people require really augments the stress and the ability to be rehabilitated. So I strongly support this motion because it'll go a long way if it is implemented adequately in improving the situation for all of us.
Thank you. Microphone 2.
Dr. Vinay Lakra, I'm a psychiatrist, President-elect of RANZCP. I strongly support the motion. As I said yesterday, although that statement in the declaration is at the lower end of the statement, but we cannot achieve any of those other statements if we are not well. This is about looking after our own. If we are not able to look after our own, then they are not going to be able to provide the care and treatment we expect them to do. As a college and profession, we're very, very supportive and be willing to part of the process to drive this forward so that we make sure that the doctors receive the kind of support and treatment for mental illnesses they do, and also support the well-being in general for them to be able to deliver services they do to the community. Thank you.
Thank you. Any more speakers? Okay, well, we'll open voting on this motion, which is on the screen. Apparently we have to hit refresh, is that right? Okay. Right. Well, I'll just ask, everybody got their vote in because it was a bit messy there at the start, so all good? All right, the motion is carried. Thank you. Now, you know, something totally extraordinary has happened here at AMA National Conference. We're ahead of schedule, and so I'm wondering if the movers and seconders of the urgency motions and if the meeting are inclined to discuss those now rather than at 5 o'clock this afternoon. Well, I'll ask those movers and seconders to come forward.